Tonight's speaker is Dr. John Strickler, who's an associate professor of medicine at Duke University, as well as the associate director of clinical research and the co-leader of the Molecular Tumor Board, and has a great deal of research experience with the newer ctDNA testing technologies. I want to thank all of you for joining the program tonight, and for those of you who submitted the many questions we received. We've tried to incorporate those questions into John's talk overall the best we can. If for some reason we do not get to answer a specific question that you have, you can feel free to email me at the end of the call. And John, with that, I'll go ahead and turn it over to you.
Thanks so much, Charles. It's a pleasure to be here tonight and to discuss this important topic with you and the group. Thank you to the attendees who joined. You know, I think first some terminology here. And the most important question here is, what is this and how does it work? And before going into that, I just wanted to go over what the liquid biopsy is. So, you know, we all have DNA in our bodies, and that's the instructions for how a cell is made and reproduces in our body. But cancers also have DNA because they're a collection of cells, and they can release fragments of their DNA into the bloodstream. That can be collected from a blood draw, and we can use that for various purposes. Like, for example, screening asymptomatic patients for maybe a cancer that somebody didn't know about. We could use it to detect residual disease after a cancer is resected. We could identify actionable biomarkers, predict treatment response, monitor tumor burden, and look at drivers of resistance. But what I'm going to focus on today is this application, which is detecting residual disease after a cancer is resected. So when you think about what this entails, so most of the DNA in our bloodstream is normal germline, what we call germline, or DNA we're born with. And what we're trying to do is trying to find a fragment of DNA that is not part of the normal DNA, it's part of the tumor itself. So that requires detecting a needle in a haystack in a way. And you need super sensitive technology to be able to find that needle in the haystack. There are a lot of ways these tests could be thrown off. So it's taken many years to get to this point where we can even detect this needle in the haystack. And there are things that have to be screened out. For example, normal DNA, and also DNA mutations that don't come from the tumor itself. They could come from just normal wear and tear on our white blood cells. And those can throw these numbers off. So ideally, when you know what you're looking for in advance, you're best suited to identify that needle in the haystack. So the topic of today is colorectal cancer and how we can use this so-called minimal residual disease testing to change how we manage colon cancer. And this is a big problem for us in the clinic because for those patients with stage 3 colorectal cancer, we know the national guidelines are that all patients should receive adjuvant chemotherapy. And yet over half of all patients are cured by surgery alone. So we know we're probably over-treating a large number of patients with stage 3 colon cancer. On the flip side, in patients with stage 2 colon cancer, the cure rate with surgery alone is 80 to 85%. And in this scenario, frequently we recommend no adjuvant chemotherapy. So here there may be patients that we're under-treating. So the question is, could we use this assay to potentially be smarter about it instead of just giving everybody with stage 3 chemo and maybe reserving stage 2 chemo for people with certain risk factors? Could we potentially use this tool to give people chemotherapy that really need it and avoid chemotherapy in people who don't? And that's really what we're asking today. And there are a couple of different ways this technology has come in the clinic. One is the so-called tumor-informed technology, which I'll go into in a moment. And then the other is just a routine blood draw. So that's the landscape here. And the way the tumor-informed MRD assay works, and when I say MRD, I mean minimal residual disease or molecular residual disease. What happens is the tumor is removed from the body, and then they create a unique pattern of mutations that are only specific to this tumor alone, nothing else, not part of that person's normal body, not part of anything else. And it creates a custom panel, and then you can draw blood and look for fragments of DNA in the bloodstream, which would indicate that there's still disease left behind. And so this is just generally how this works. Now, there are also, as I mentioned, blood-only tests as well, where they take a predetermined static panel of mutations and then add what's called a methylation pattern. And so sometimes people will receive what's called this tumor-naive MRD assay or blood-only, each with its own set of data behind it. So I wanted to jump in now into the questions. And one person asked the question, what is the difference between circulating tumor DNA and genomic profiling? And this is a really great question, because truthfully, I don't have an easy answer for this. I consider circulating tumor DNA to be fragments of DNA in the bloodstream. The act of analyzing those fragments of DNA is genomic profiling. So I'm not sure if that answers the question, but circulating tumor DNA is just a description of the genes. And then genomic profiling is more of a description of how we identify what those genes are. Next question I got is, does circulating tumor DNA have a role in oligometastatic disease? And the short answer is yes, in certain cases. And there's some data out of Italy that shows that we can potentially apply this to people with metastatic disease, at least in certain scenarios. Ideally, this is a test that should be used when you have a question you need to answer, and that blood test can help us. Maybe if we're on the fence about what to do, it's really nice for pushing us one way or the other. This is data out of Italy, enrolled 113 patients, all of whom had stage 4 metastatic disease, all of whom went for surgery with curative intent. And then they drew blood at regular intervals after that surgery. And I know not everybody is familiar with looking at these disease-free survival curves, but the key thing to know is the best disease-free survival is up here, and the lowest disease-free survival is down here. And I would say that the blue curve clearly has better disease-free survival than the red curve. And this is telling us the blue curve are those patients who are ctDNA negative immediately after surgery. And then this is people who had negative circulating tumor DNA over time or with serial draws. So this is a pretty wide gap. Unfortunately, those patients who had positive circulating tumor DNA immediately after surgery, most of them had the disease come back within 3 years. And then, of course, there's survival data as well that shows that survival is incredibly good for patients who were negative both after surgery and over time. So it is a very strong prognostic marker. I think the challenge that many clinicians have with this, though, is that, it's a little bit like looking into a crystal ball, but really what we as clinicians want is information that will change what we do for that patient. So just knowing someone has a good prognosis or a bad prognosis is one thing. It's another to say, okay, and I'll use that information to make myself smarter about how I treat this. So that's where we are in the field. Next question, are there sanctuary sites where circulating tumor DNA testing works less well? This is a really outstanding question, so I want to spend a little bit of time on this. Circulating tumor DNA is secreted into the bloodstream, and there are certain compartments of the body that are notorious for having high levels of secretion into the bloodstream, and other parts of the body that are notorious for having low levels of excretion into the bloodstream. So the two parts of the body where you see the highest levels of circulating tumor DNA would be liver metastases and lymph node metastases. Those are the two areas where this test is extremely effective at detecting fragments of DNA in the bloodstream. On the flip side, peritoneal disease and lung disease are two parts of the body that are notorious for having low shedding of circulating tumor DNA in the bloodstream. And in fact, there have been some cases where there have been clinically apparent lung metastases on a CT scan, and yet the circulating tumor DNA is negative. And that would be something that's unique to the lung. Next question is, can circulating tumor DNA testing be done while a person is on chemotherapy? And the answer is yes, absolutely. You can have circulating tumor DNA testing done at any time. Just keep in mind that when a person is on chemotherapy, their tumor is being suppressed. So they are far more likely to have very low levels of circulating tumor DNA detected while on chemotherapy. So a negative result does not mean the cancer is gone. It just might mean that it's been put in remission by that chemotherapy. Wrap up with a few questions. Can Signatera still be done if my surgery was 3 years ago? Absolutely. I love to order Signatera, even on folks who have had surgery many years ago. It works just as well in my experience. How often can and should you get ctDNA tests done? That depends on what question you're trying to answer. I think the standard interval is 3 to 6 months. And we just talked about the intervals, 3 to 6 months. There is a surveillance plan through Signatera. So they have a way to ping us to make sure that folks are not slipping through the cracks. But I would always encourage patients to make sure that their very busy doctors and nurses are not forgetting and making sure that you stay on that. But I think every 3 to 6 months would be the ideal interval. Have I ever seen cases of discordance between CEA level and circulating tumor DNA level? All the time. In fact, that's one of the main reasons why I order the ctDNA, is because there are times where I find the CEA to be highly unreliable. And I think if you were to choose what's more likely to be true, it's almost certainly going to be the circulating tumor DNA in most circumstances. But just keep in mind, no test is perfect. CEA is a particularly flawed test, but ctDNA also has its issues on occasion. And do you repeat a CT scan at the time of a positive circulating tumor DNA test? The first, usually yes. I'm also wanting to, that's also a time where I might consider a PET scan or an MRI to make sure we're not missing a sanctuary site or a place where we can't find it. And then last question today is, how do the results of circulating tumor DNA testing influence treatment options? Does a high number indicate poor outcomes? In general, the lower the better. So I do think that the absolute number does portend just volume of disease. And I can't give you a straight answer for how it would influence treatment options, because no two people have the exact same scenario in their lives. But usually I do not order the test unless I have a plan before I order it for what I'm going to do with the result. So it's important before that test is ordered and the test is performed that we have a playbook in place for what to do if it's positive and what to do if it's negative. So with that, I'll wrap up. Thank you very much, Charles.
Yeah, Dr. Strickler, I wanted to follow up one question. Could you speak to how much earlier the ctDNA can detect a recurrence than the routine surveillance with CT?
It's right here. So on the Signatera data, this is based on several hundred patients. On average, circulating tumor DNA would detect recurrence about 8.5 months or 8.7 months before it would be seen on a CT scan. That's just an average. So there's a bell curve. The maximum lead time is up over 16 months, at least in this study.
Okay, well, with that, we'll say thank you, John, for a nice talk. I'd like to thank everybody for taking some time out of their evening and submitting the questions for us to build this program.